Hello and good afternoon, everyone. My name is Melissa Flores, pronoun she, her, and I'm the Senior Outcomes Manager with the Department of Social Work Programs here at the Hospital for Special Surgery. I'm accompanied today by three of my esteemed colleagues, Roberta Horton, who will begin our program with opening remarks, Joan Westrich, who will be introducing our speaker today, as well as Adina Batterman, who will be facilitating the Q&A portion of our program. I would also like to take a moment to acknowledge Nadia Murphy, Priscilla Calvache, and Mary Rose Carey, who are all working their magic behind the scenes to bring this talk to you today. So as we begin our program, it is my pleasure to introduce Roberta Horton, Assistant Vice President of the Department of Social Work Programs, to welcome us all today and share some opening remarks. I'm turning it over to you, Roberta.
Thank you, Melissa. On behalf of the Department of Social Work Programs and Case Management Social Workers, welcome to our annual speaker event in honor of National Professional Social Work Month. I would like to give a special acknowledgement to Mavis Seahouse, our Senior Director for Ambulatory Care Social Work Services, and Dr. Jillian Rose Smith, Vice President and Chief Equity Officer, to our Social Work Staff Development Committee, chaired by Mavis, and to our Speaker Committee, Melissa, Joan, and Nadia, all of whom work behind the scenes to bring this very special program to you this afternoon. Congratulations to all HSS social workers for the integral role we play each and every day, identifying and addressing the concerns of the patients, families, and communities that we serve. We are excited to bring this timely and relevant program to you today on the topic, Understanding Ableism and Disability Allyship in the Hospital Setting, promoting a model of inclusive healthcare and resilience across the lifespan. Now, I'd like to turn it back over to Melissa.
Thanks so much, Roberta. Now I'd like to introduce Joan Westrich, Social Work Coordinator of the Early RA Support and Education Program, and my colleague, along with Nadia Murphy, on our Department Speaker Committee. Today's event would not be possible without the close collaboration of this team. So now I'd like to turn it over to you, Joan.
Melissa, I am very honored to introduce our esteemed speaker, Dr. Reji Mathew. Dr. Mathew is a senior clinical social worker at the NYU Student Health Center's Counseling and Wellness Services. A neuroscience-informed psychotherapist, she is also adjunct faculty at NYU Silver School of Social Work, an expressive arts therapist, and disability rights advocate. Dr. Mathew has had the privilege of being part of mental health teams deployed to respond to communal crises ranging from the HIV/AIDS pandemic, 9/11, Hurricane Sandy, gun violence, and most recently, the COVID-19 pandemic. In her presentation, Dr. Mathew will provide a comprehensive and critical lens through which to understand the lived experience of people with disabilities as they interact with healthcare and other systems. Equally important, she will invite each of us to examine our own ableism and/or bias tendencies. And so as not to leave us without a roadmap, she will educate us about the history of disability rights since the landmark Americans with Disabilities Act of 1990. And significantly, she will identify tools, strategies, and resources to support us in our mission of providing a consistently welcoming, safe, and inclusive space for all patients at HSS. It is my honor to present our 2023 Social Work Month speaker, Dr. Reji Mathew. Hi, Dr. Mathew, sending you a very warm welcome. Thank you for being with us. And without further ado, I pass the virtual baton over to you for your presentation.
Thank you, Joan. Thank you, Melissa. Thank you to the Hospital for Special Surgery Social Work Department. It's an honor to be with you here today. Move to the next slide. Next. So my name is Dr. Reji Mathew. I use she, her pronouns. I also want to describe myself. I'm a woman of color wearing glasses with shoulder length brown hair, wearing a brown and white shirt. I want to first ground myself in the lens that I'm speaking from today, so you know the perspectives that inform my worldview. First, I'm a narratologist. My academic area of study is studying the construction of stories and how stories evolve, create, and move through time. I'm an arts reporter for the disastershock.com, a humanitarian aid group. I'm also an arts accessibility activist for anti-racist art teachers. I'm also a registered expressive artist, artist and arts therapist. So the creativity lens is central to my worldview. And lastly, my own direct lived experience is central to my talk today, in that I grew up before the ADA. So I have the lived experience of knowing what it's like living in the world before the ADA, and also have had the great privilege to be here and to be present to see the evolution of the disability rights movement evolving to the world and language of disability justice, which I will speak to. Next. I want to disclose that I have no financial relationships to disclose. Next. I'd like to briefly review the learning objectives for today. We're first going to define ableism, its history and impact on the delivery of healthcare. We will highlight barriers identified by disabled activists in accessing healthcare. We will look at the gaps in support for healthcare trainees, healthcare professionals, and patients living with disabilities. And then we will explore resources and strategies for allyships for the disability community. Next. I would like to anchor my talk first with the words of a transcendent, iconic clinician, Dr. Paul Farmer, who we lost too early in the year 2022, the director of Partners in Health. So I'd like to anchor my talk in the spirit of his ethos. Dr. Paul Farmer says, if access to healthcare is considered a human right, who is considered human enough to have that right? Now, these words resonate deeply in my soul. And how I understand these words is that when we use terms, ideologies, labels to marginalize people and separate them from their basic shared humanity, we create a cultural, class, and healthcare divide. So this brings me to the first concept in thinking about disability, allyship, and accessibility. Next is that disability as a social construction. What does that mean? A social construction is an idea that's been generated and created and accepted by people in society. Class is a social construction. Race is a social construction. That we all have been socialized, deeply embedded biases about how to think about disability. Next. So let's do a brief exercise together. Let's look at this screen. Let's look at this image. What is that on the screen? The lay term is that they're a pair of eyeglasses. The medical term would be, oh, okay, that's an assistive device. I actually use this assistive device. This assistive device is the most widely used assistive device around the world. Next. Now let's look at another assistive device, a chair and glasses. Both are assistive devices. But what is the difference? Take a moment and check in. Notice any inner judgments. What do these two different assistive devices say about a person's basic humanity? Do you notice any inner judgments? Check in for a moment. Next. We are at a profound moment of cultural reckoning in our society. We are in a process on every level of undoing, unlearning, and relearning. We know of the profound effects of historical racism on our culture and the excruciating pain of that construction. We know the cost of classism, the lack of access to resources, education, opportunities. We know the history of sexism and gender inequity, how people with different gender identities have had to fight through time to be able to have equal privilege and access. So this brings us to the subject of ableism, that ableism is an ism. It is a classification. It is an identity and a construct that has marginalized people, that has separated them from their humanity, and stood in the way of access to resources, opportunities, and privilege. Next. So what is ableism? Ableism is the discrimination and social prejudice against people with disabilities on the belief that there is a typical ability that is superior. At its heart, it defines people with disabilities as fixing. And like racism and sexism, ableism classifies entire groups of people as less than, which triggers harmful stereotypes, misconceptions, and generalizations. Next. Now, where does the social construct of ableism arrive from? It arrives originally from the medical model of constructing and understanding disability. So there's the medical model of disability, definition of disability, and then there's the social model of disability. Next. The medical model of understanding of disability is that disability is a diagnosis, an injury, an illness, a condition that needs to be fixed or cured or alleviated, and that disability should be dealt with by experts through interventions. So in this definition of disability, the onus lies on the person with the disability to conform to society. Next. Dr. Sherry Baldwell from the Mass General Brigham University Hospital is a physician and a person with a disability who experienced a spinal cord at a young age. She says in her words, she said that even if disability starts with a medical condition, it's the environment that determines how disabled one feels. What this means is that when you keep the definition of disability within a medical focus, it leads to stigma, and it perpetuates the idea that those with disabilities are less capable, that the reliance on the medical model alone does not afford people with disabilities fair and equal access to realize the same goals than those without a disability. Next. Now, when you look at ableist practices, they're rampant and everywhere. There's ableist language, any language that devalues people who have a disability. So for example, outdated, archaic words such as handicapped or the R word, they reflect archaic and degrading ableist ideas about people with disabilities. Inaccessible design. Even though a passage of the ADA, the American with Disabilities Act, has been over 30 years now, we still have a long way to go to make buildings, housing, public spaces of equal access to those who have disabilities. And then there's the deep internalized biases we all have, consciously and unconsciously, the harmful messages of what constitutes a full person. And then the ideas about accommodations being a privilege and not a right. Next. So why is disability relevant? First, disability is a lifespan identity. The disabled population is the world's largest majority, which anyone can be part of at any time. It is an estimated 1.3 billion people in the world, represents 16% of the world's population. That's 1 in 6 of us. So when I say that disability is a lifespan identity, the problem with ableism is that it does not allow for the accurate portrayal of the human journey being one of human vulnerability over a lifespan. That means that we all will need accommodations or adaptations over our lifetime, that anyone at any stage of life can become a member of the disabled community, that human vulnerability is innate to the human journey and not an aberration. Next. The World Health Organization in the year 2023 clearly states in their public statement that people with disabilities face all kinds of barriers in the health system: lack of knowledge, negative attitudes, discriminatory practices amongst healthcare workers, inaccessible facilities, and the lack of reliable collection and data analysis on disabilities throughout the world. Also, it's important to know that disability is a diverse community and requires a diversity of approaches, not a one-size-fits-all. There's invisible disabilities, visible disabilities, psychiatric disabilities, neurological disabilities, low vision, hard of hearing, language, intellectual disabilities. That each disability is a unique thumbprint, a unique way to move through the world, and needs a diversity of approaches with unified principles. Next. Now, the social model of disability say, no, the problem is not with the person. We don't have to keep, if you look at this illustration, fixing this person. Let's work and support this person as they are in the world, and let's instead create ramps so this person can have access to this space. Medical and human innovations are invaluable, but without a model of inclusion and accessibility, we are marginalizing significant parts of our population. That there are many people that show up in the world in a diverse presentation of mind-body diversity, and that without accessibility, we are not allowing for a full quality of life for people with disabilities. And also, narrowing a person's narrative to overcoming is not acknowledging the diversity of how people move through the world as they are. Next. So the social model of disability say the problem is not with the person. The problem is the way normalcy is constructed to create a problem of the disabled person. Next. Many disability activists talk about what's called the ableism bias, the framing always in popular narrative of overcoming disability. That doesn't mean that medical and scientific innovations aren't invaluable. But when we focus on overcoming disability versus creating accessibility paths of inclusion and accessibility, we are not respecting and allowing people to move through the world in the way as they are. And also it's reinforcing that the non-disabled experience is preferable or serious or superior to the lived experience of the disabled person. Next. So what are we saying here from the voices of disability activists? That the dichotomy of the able and disabled framework is a flawed dichotomy, that we want to move from a model of ableist normalcy to a model of neurodiversity. What does that mean? Disability means in this new framework that there is a diversity of ways that brains and bodies move through the world. That in this diversity of ways that brains and bodies move through the world, we need a diversity of tools, we need a diversity of resources and spaces for everyone to participate in the world in their way. Now, this is an important theme that comes up in many of the activism communities that I partner with. I hear from many people in the disability community always trying to fit in, particularly the people with invisible disabilities. For example, a person that I spoke with who had RA had an invisible disability, invisible to her coworkers. And despite fatigue and occasional flares, she always managed to push through. But recently has been having difficulty keeping up with her workload and feeling ashamed about being the weak link. And I hear this all the time. I'm pushing myself. I can't fit in. Why can't I do it that way? And this is an opportunity where I present this model of neurodiversity. That accommodations does not mean a change in expectations. That entry point does not equal endpoint. What we would rather advocate for is, can we create an accessibility path that allows you to move through the world through your process so you can be an equal ally in this space? So again, in this more evolved conceptualization of disability, it's to acknowledge that there's a diversity of brains, a diversity of way of problem solving, a diversity of bodies and the ways that bodies move through the world, and creating a world that honors that and creates the tools, access, and spaces for people to participate equally in community to their fullest potential. Next. In my work as an arts reporter for disastershock.com, I have a reporter's notebook that looks at the expressive arts as a tool in integrating the mind, body, and spirit, and both in healing and trauma recovery, but also as to promote community-based, the best community-based arts practices. I'd like to introduce you to the Creative Art Growth Center in California. I will be interviewing the central voice here in this video, Tom DeMaria. This is a center which has been successfully running for over 40 years. It is an artist space. It's a studio for artists. It's not a vocational rehab center for people with disabilities. It is a place where people with disabilities, who are also artists, can express themselves, have access to tools, are being allowed to find their way with their process with a wide range of diversities. So I want to present this short film to you as an illustration and a metaphor of what does it look like when we create spaces that respect neurodiversity, offers accessibilities, honors the process and dignity of each person, and what a loss it is to the human story when there are not such spaces. That story is so meaningful to me because when we don't challenge these conceptions, it's such a loss to all of us. The potential of how people can evolve in the world, find their place and voice, and express themselves and contribute to our common culture. So what I want to gather from that video is that disability is not just a diagnosis. It is a culture with a voice and an identity. Next. Disability activism history began with the landmark event in 1990 of the Americans Disabilities Act, the ADA, which began the beginning of the disability rights movement, which then led to the Center for Independent Living movement of disability activists saying, no, we are full people. We can be in the world on our own with equal access to everyone else. And then at the 30th anniversary, historians and researchers were reviewing the history, and what emerged was the idea that we are still 20% of America and we are still invisible. The disability rights movement has evolved to a powerful new conceptualization, moving from disability rights to disability justice. So what's next? Now we have a powerful plethora of voices in the disability justice scholarship and disability rights justice movement, deepening the narrative of the disability identity and the place in the world. Voices such as Lydia Brown, Alice Wong, Judith Heumann. Next. I want to acknowledge Judith Heumann, who recently passed away this month, and she's considered the mother of the disability rights movement, and want to just speak with her words for her, that change never happens at the pace we think it should. It happens over years of people joining together, strategizing, sharing, and pulling all the levers they possibly can. Next. So what is disability justice? The great iconic writer and activist Audre Lorde once said that we do not live single issue lives. So the evolution of disability rights to disability justice is moving towards a new thesis of dissolving cognitive, systemic, and conceptual barriers towards disability identity, studying disability as a form of human diversity, and also recognizing and respecting disability as a culture. Next. What is disability justice? Disability justice centers on intersectionality and the diverse ways systems of oppression amplify and reinforce one another. The limitation of the disability rights movement in the origins is that the focus of the disability rights movement was on activating legislation, laws, policies. But what the disability justice movement says, no, the problem with accessibility and inclusion is deeper than that. Disability is very much interwoven intersectionally with other themes in society. Next. This leads to the idea of what's called intersectional ableism, which is a profound conceptualization. What does this mean? That ableism intersects with racism, systemic racism, classism, patriarchy, colonialism, and other types of oppression. That people with disabilities are diverse, and they may have multiple marginalized identities that create barriers to be able to have the right and the access that they need and deserve. That disability identity is one that cuts across and moves across every other identity of race, culture, class, gender, age, and nationality. And also, unfortunately, the disability identity, there's inequity even within the disability identity, and there's also hierarchy. Which disabilities get the funding and the resources they need where other communities don't. It's particularly difficult for the invisible disability community, people with psychiatric conditions, invisible conditions where there aren't cultural markers or signifiers, where it would be easily to locate what kind of social space or social support to provide to this person. Next. Another sort of thesis of the disability justice movement is the model of interdependence. Author and disability justice advocate Mia Mingus talks about, with disability justice, we want to move away from the myth of independence, that everyone can and should be able to do everything on their own. This is really important. She says, I'm fighting for interdependence that embraces the need to tell the truth, that no one does it on their own, and the myth of independence is just a myth. This is really important to me because as a narratologist, I've often observed the one sort of narrative that's very hyper amplified and overplayed in American capitalistic mythology is the mythology of individual heroics. And what we know is that people succeed because they have support, they have mentors, they have access to resources, they have people that invest in them. So the narrative of individual heroics, of hyper superhuman resiliency, is a flawed narrative, that people do well from an interpersonal perspective, an interdependent perspective, that people do well because sources of support are in place. So this is a really important thesis in terms that the disability justice advocates are speaking to, because this idea of hyper-individualism is very much embedded in the way insurance structures, healthcare, resource structures are set up, that it's not a model set up for interdependence over the lifespan. Next. So knowing the context of ableism, the biases that are in place, the systemic injustice, how do we then build a model of allyship? First, I first want to reference an article that was published in the New York Times last fall, in October of 2022. And it was a very painful article for many of us in the activism community to read. And it was an article with the lead of Dr. Lisa Izzoni, who is a professor of medicine at Harvard. And the title of the article is, "These Doctors Admit That They Don't Want to Work with Patients with Disabilities." For a quarter of a century, Dr. Izzoni, a professor of medicine at Harvard, heard the same story doing research with hundreds of people with disabilities, that healthcare was substandard, medical offices were not accessible, and doctors did not treat them with respect. Everywhere I looked, there were disparities, Dr. Lazzoni said. Yet what patients told her was no surprise, given her own experience with multiple sclerosis and using a wheelchair. So as a physician, she decided to take the next step and created focus groups to really begin to explore this narrative, to say, what are the barriers that are presenting people in private practice settings throughout the country in not providing the care needed to the people in their community? So this problem of accessibility, treatment with dignity, accessible offices is a current problem in the here and now. So how do we build a model of allyship? Next. First, allyship principle is universal design for all. We are all on a journey of human vulnerability. An accessible world is for all of us, not only for people with disabilities. That allyship is to create a world that's barrier-free, where people with disabilities can live, work, love, and study and imagine a life to their fullest human potential. And then it will take all of us in each of our communities to create what we call accessibility paths. What are we talking about accessibility? Exam room accessibility? Intake accessibility? It's interesting that when the pandemic happened, options opened up overnight for accessibility for the disability community. Is the intake accessible? Most of the time when people come for their appointment, they're in a vulnerable, activated state. They don't have access to all of their language and to think of it clearly. Is there an opportunity to send questions beforehand, to send questions afterhand? Is the exam room accessible? Is the intake accessible? What are points of entry that people can come in and they can feel heard, seen, and also that their story and context can be presented, that healthcare is provided in the context of each person's narrative? Next. The second principle of allyship is disability humility. People with disabilities are innate problem solvers. No matter what symptom they're presenting in a hospital setting, it's important to remember that they have lived in their body their entire lives. So they're coming with a certain degree of lived expertise and a lived experience of how they've navigated through the world. So Dr. Reynolds from the AMA Journal of Ethics say that numerous studies demonstrate that able-bodied people assume that the quality of life of people with disabilities to be lower than themselves. But what they downplay is that when there are changes in status and healthcare status, there's the establishment of new and different abilities, new expectations, new flourishings. What am I saying here? That oftentimes I've heard in the disability community, particularly is the idea of being given the diagnosis, you have a progressive condition. And that itself creates a frame of loss against an ableist ideal. But thinking of it to say transition versus progression, that when people are supported to transition to the next phase in the journey of their body and provided the right tools, there could be the highest quality of life in the next decade of their life. So really honoring the lived experience of people with disabilities and know that they have lived in their body for the lifetime and found their way through the world, and drawing in that lived experience as you do your treatment planning. Next. Another principle in disability allyship is person first versus identity first. We're now really bringing in the language of inclusion, names, pronouns, proper pronunciation of names. But another thing to add to the toolkit is recognizing that in the disability community, people may identify as person first or disability first. So for example, person first language would be person who is blind, person with a spinal cord injury. Disability first would be a disabled person. I'm an autistic person. Now, identity first language is really powerful because in disability activism, there's a powerful reclaiming of the disability identity. Say, no, this is central to who I am. This is central to my lens and to my worldview. So this is something to also include in the intake and the assessment. What location does the disability identity have in the person's life? And also to be open and fluid about it, to simply ask, and to know that we are all people in process. So you may identify as person first in your 20s, but you may identify as identity first in your 30s and in 40s as you evolve. Next. The next issue that comes up a lot in disability allyship is the issue of communication and the problem of dehumanization. Everything begins and ends with a conversation in medical care. And what's important to remember here? What we know in mental health is that social and relational medicine, eye contact, hearing, listening is the foundation of the psyche and psychological development. The one thing I've observed as a narratologist in listening to stories over time is that one moment of meaningful human recognition can illuminate a life. That self-care is derived from a memory of self-care. So those clinical encounters and those conversations are so critical. How many times have I heard people going to a clinical encounter and not feeling heard, seen, not feeling that they've been asked the right questions, not being asked their opinion on something, all getting truncated into a brief 20-minute encounter. So some things to be mindful is what comes up in the disability community is infantilism, asking for consent before touching a mobility aid, talking directly to the person, no matter what the limitations are, engaging their consent and asking for their participation in the counter. Also being mindful of disability biases. Because of the disability, are you asking about sexual health, prenatal health, asking about what are your summer plans? Do you travel? These biases are deeply embedded in, so we don't allow to know the full story of the person. Speaking to the client first, thinking of symptoms in the context of someone's living, breathing narrative, and knowing that communication is a process. Is there an opportunity to metabolize questions beforehand and afterhand, that each person has their own processing style? And remember that we draw from self-care is an acquired capacity that comes from the reservoir of being cared for. It comes from an acquired capacity from being treated with dignity. So each moment of human recognition builds that reservoir of being cared for, of being able to reference your self-care and being able to engage more actively in the self-care process. Next, the next allyship principle to be mindful of is disability bias. And we all have that, and it's okay. Biases are deeply embedded into our experience of looking at the world through socialization, education, history, culture. There's an interesting resource at Harvard University called Project Implicit, and it's a wonderful tool to use in departments, in staff meetings, for staff to get together and take an implicit bias test and then look at the results to say, wow, I didn't know I had a bias around asking about sort of prenatal health or sexual health, or to being able to ask about what are your life goals? Do you want to plan to live away from home? What kind of support and resources that you need? That bias and being mindful of bias, the kinds of questions we ask, the kinds of questions we don't ask, the kinds of questions we invite people to ask, is all intrinsic in our bias, our implicit bias system. So it's a really powerful tool to integrate into our practice to keep mindful of our biases. Sometimes what I'll say is there anything I haven't asked you that you think that you would like for us to talk about for a minute that I may not be informed about? Can we keep that question open? Or, I've never thought about that question, or I have never been presented with that. Can I research that or look into that a little bit? And the next time we meet, we can dialogue about that. Next. The next allyship principle that's so important, and this comes up so often, is the insurance reimbursement structure in the healthcare system. The reimbursement system is designed for prevention care to prevent disease, and the reimbursement system is also designed for acute or emergency care. What the reimbursement healthcare system is not designed for is resiliency care. What do I mean by resiliency care? Is that most often people with chronic conditions need a lot of resiliency support interventions to maintain the highest quality of life. What is the definition of health according to the World Health Organization? It says that health is a state of complete physical, emotional, and social well-being, and not merely the absence of disease or infirmity. It's so meaningful to me that at the Hospital for Special Surgery, the social work department has curated and painstakingly cultivated in an attuned way a model of resiliency care. That resiliency interventions, support groups, advocacy programs, case management, ambulatory care is central into integrate into the treatment planning. That it's not that healthcare for long-term well-being of a chronic condition is not just alleviation of an acute distressing symptom. It's also asking questions about what are the interventions that could really support your well-being and maintain your resiliency at the highest quality. So over and over again, you see all of these disappointing outcomes of services being cut off, services being offered only for a short period of time, of OT, of PT, and not being people not being able to access it on a regular basis to maintain their highest quality of life. So in the models of the future, which is why I'm also involved in policy work, is that resiliency care, maintaining well-being, is an equal and viable model of healthcare in addition to prevention and acute care. Next. The next allyship principle that's really important is disability representation. There's a quote, that's a phrase common in the disability movement, that says nothing about us without us. And what I've learned in traveling in such a diverse disability world, from the visually impaired community to people with chronic conditions, neurological conditions, to the spinal cord injury community, the direct lived experience and the wisdom of the various disability communities is invaluable. So it's so important to commit to having representation of disabled persons on staff, or with medical departments, to partner with disability communities and really stay close to the pulse of culture. What is the innate lived experience and wisdom of how this particular community moves through the world? What are the innovations and insights that they can offer to my patient populations? Building a peer advocate model, that when people come in and they're newly diagnosed, that you immediately have a peer advocate for someone to connect to help them to find their way and to cultivate that resiliency. Having alliances with members of the disability community to help keep your treatment plans current and robust and innovative. That disability representation for the communities that you serve is absolutely critical. Lastly, what I want to say is I want to present that this is what I've learned in the world of the intermodal expressive arts, this disability as a path of creativity. Next. The one thing I know from my lived experience living in the world before the ADA and after the ADA, and having the privilege to be here at this moment in time, is I've seen tremendous innovation coming from the world of disability. So the world of intermodal arts in the world of in the community of independent living movement. The innovations of arts expressions, of teaching people how to live in the present moments through arts initiatives for the Alzheimer's community. Yeah, that maybe the goal is not to be able to recall the past, but to live in the present moment with as much direct mindfulness as possible. Again, a reconceptualization of health and well-being. The amazing innovations in music and music therapy with the neurodiverse community, being able to access language. And then lastly, what we saw in the Creative Arts Center, that when we create a space of accessibility, access, neurodiversity, the immense possibilities when people have access to those kinds of paths. So the Creative Arts Growth Center is a model of what's possible, and also a model of what's lost when we don't create those kinds of spaces. Next. Lastly, what I want to say is that the most important thing is to recognize that disability is not a diagnosis, it's a lens and it's a worldview. It provides a perspective. For example, the deaf community talks not only about hearing loss, they talk about deaf gain. That it's not just a loss, but when in that they also gain culture and they gain a language within themselves. Healthcare policy activism. Ableism is not an issue that can only be addressed on a person-to-person level. It's systemic, it's historical, it's organizational. So ableism is also an issue that must address systemic inequities. Next. In my work, I do direct work, education, but I'm also involved in policy work. That doctors and people in power have a lot to contribute in terms of advocating for healthcare policy advocacy, but also challenging the embedded deep ableism biases behind healthcare policy, reimbursement structures, and some of the policy positions of increasing access for all, increasing access to not only acute or preventive care, but also resiliency care, advocating for reimbursement for timely mobility devices, medication and treatment care, and also disability justice, improving social context and not only defaulting to the mythology of individual heroics. Next. Why this is so important to me is that I work with Disaster Shock. It's an international humanitarian aid group that provides psychological first aid to disaster relievers around the world. And what I've seen firsthand from being part of this organization is that this model of resiliency care that we're talking about will be absolutely critical in the upcoming decade of healthcare needs for the upcoming challenges in our society. We have the emerging, increasing healthcare impact of the disaster-related stress. We have an increasing aging population in the US. We have the enormous number of people who are now going to be facing long COVID and the long-term chronic condition effect of long-haul COVID. And we're also still in the grips of a post-pandemic mental health crisis. So what I'm saying here is that the disability lens, these activists, these voices, this history, the insight, the lived experience, the innovations has something to offer for the challenges ahead. That there will be countless communities that will be in need of resiliency care, of mental health support, of access to creative, accessible spaces, who will need complex, intersectional, integrative healthcare treatment planning. Next. We've collected and gathered a series of resources for you, of organizations, resources, things to think about. Next, Melissa. References on disability justice, access to direct resources. Next. Links on videos about thinking more deeply, access links to activists, books to read for. So I want to thank you for your time today, for being here present to process this difficult concept with us, and how it's a certain central model to be able to think about for the coming decade of complex healthcare needs.
Hi there. I just want to thank you, Dr. Mathew, for this elegant and profound presentation to help us understand a little more about disability humility, ableism, resiliency, diversity, access, and how all of this impacts the care we give to people coming into our healthcare institutions. We're going to start our Q&A, which is an opportunity to generate discussion, and I imagine your talk will be generating discussion as we continue to process this, and also to hear from our attendees and participants. But before we start, I know that you wanted to share a few words to help frame this discussion before we start. So I wanted to hand it back to you.
Yeah, thank you so much, Adina. I guess I first want to acknowledge this moment in time as a narratologist, We are in a profound moment of cultural reckoning. There's a lot of cultural pain in our society, and it's almost like a soul's cry being unearthed. So I want to say that I first want to acknowledge that pain that people have had to hold for a long time. But I also want to create a space where this would be a space of bridge building, that we are all relearning, unlearning, rediscovering. And when I think of bridge building, is that we're all in process and we're doing the best we can. So I hope that this could be a space of curiosity, compassion, and know that it's a process to recognize that we have biases, and it's a process of undoing those biases. Because everyone loses when we don't create a safe space, and everyone gains when we work together to grapple with the complexity of what we just talked about. So I just wanted to create that safety and acknowledging the pain and how we all, we fall short in trying to grapple with it. And I wish the responses to these needs could be quicker, but it is a process, and I can acknowledge the frustration of that.
Thank you. Thank you for that framework as we begin. We have a few questions that people submitted when they registered, so I'll start with those. First question is, can you discuss visible and invisible differences that may be present in individuals with disabilities? For example, those present in individuals on the autism spectrum.
Well, the difference, I would say, with a visible disability, it's visible. So there's a cultural recognition and a cultural marker of how people in a community may be able to conceptualize the space that someone needs with that visible condition. I'm not saying it's easy, but with an individual condition, there are so many invisible challenges: perception, energy conservation, fatigue, sensory sensitivities. And when you can't see it, it's harder to conceptualize, how can I support this person? Or what is the space that someone needs to be able to flourish and participate in community in an equal way? So I think it's all of our responsibilities to really do due diligence and get educated, to say, okay, I know this person, or this is a colleague of mine, or I want to partner with this community. Can I take the efforts to educate myself to say, what are the dynamics and struggles or the support that this person needs? And then partnering with them is, then how can we create social spaces that help people to participate in community? So for example, in the autism community with children, one of the interesting innovations recently is the many movie theaters have partnered with autism communities to show films in the movie theater at times where there's less sensory stimulation. So children can go see a film with parents at a time where they can enjoy it and they won't be overstimulated with the stressors of maybe a regular scheduling film. So again, that's why I'm in the world of the expressive arts, because creativity always inspires me to say that there is a way. There is a way to find our way through this.
Thank you. Next question. Why don't more diversity, equity, and inclusion DEI programs in New York City address accessibility?
That's a very difficult and painful question. I think it goes back to what we said of all the deep embedded biases that we've internalized, but also the deep biases that are embedded in policy, in theory, in healthcare delivery. The world is set up for an able-bodied person to progress and move through the world. When we think of disability, it can evoke fear and the fear of vulnerability. So I would say that when you see that happen, that there is a DEI initiative, raise the question to say, can we have this as part of the collective dialogue here? Again, with compassion and curiosity, to ask, there's what's called calling in or calling out, to ask the question, say, could this also be part of what the narrative here is in terms of access? So what I would say is that we're going through a profound, I think, there's a colleague of mine who's an anthropologist, and from her lens, because she has a cross-civilizational perspective, to say, we're going to look back at this point in history and say, wow, what a profound reconfiguration. moment it was in time. So I would say these changes are painstaking. We're not doing it perfectly. We're not casting the widest net possible. And whenever you see that, if you can partner and ally with it, ask for that. Ask a question with compassion and curiosity and build that bridge.
Thank you. I was struck in your presentation by the concept of disability humility and how that figures into all of this. Moving to policy, and this is sort of a bridge from what you're discussing right now, is why are disabled individuals marching outside of Governor Hull's office right now?
Well, recently there's been two pieces of legislation that have been blocked. One is the cancellation of expressive arts therapies. And that was very concerning because, you know, when you only say that verbal therapies are the ones that's going to be reimbursed, that's a very ableist notion. Expressive arts therapies, music therapy, art therapy, movement therapy has been shown to be significantly vital in the recovery of people with brain injuries, people with cognitive disorders. There's studies showing about the Parkinson's. I've done work with movement interventions with people in the Parkinson's community where there's close to 42 peer-reviewed studies. So again, that's an inherent ableist bias to say that only verbal therapies will be reimbursed and not these others. The other recent advocacy protests that have been happening recently is the community of people with disabilities who've aged the 18 and above and are ready to transition to the community as full independent adults, and the lack of services, resources, and access for people to make that transition. Another example of an ableism, inherent ableism bias, that our world and our structure is not set up for a diversity of people to move through the world in the way they move through the world. And that's how I like to think of neurodiversity, that brains and bodies are different. And what we want to do is set up a world in a way that all people can move through the world in their way, through their process.
Thank you. Can you speak to the intersectionality of diverse identities, Black, Latinx, Asian, gender identity, sexuality, orientation, et cetera, and disability?
Yes, I love the idea of intersectional ableism, that you cannot talk about ableism without recognizing the multi forms of oppression that exists in our society. So some people have multiple marginalized identities. The queer community, the African American community, which we know historically has been marginalized in the healthcare system. And then if you add disability to that, for people to recognize when someone comes into your office, what are the multiple barriers that they're facing? And acknowledging that, recognizing that, and then being an ally and partnering with that, asking them about that. How can we be your ally? How can we be your support? To know that people that are marginalized in multiple ways, and that the only form of ableism that will really help this narrative move forward is one that recognizes intersectional ableism, that ableism intersects with all of these other identities, and that it's intrinsic to the sort of primary ways of oppression in our society.
Thank you. Why is expressive arts therapy so important?
In the expressive arts, we talk about intermodal processing, that the human mind is an intermodal mind. We can see, we can hear, we can imagine, we can feel. So when we create, and I think of an accessibility path as an intermodal path, that people can express, articulate, construct their voice and their narrative in a multitude of ways. So for some people, it's the visual system. Other people, it's in the Parkinson's community that I've worked with, it's the movement system. For other people that I've worked with, recently did a piece on music therapy, it's the musical system. That each path is a viable path of human development, of human expression, of human construction, and also a way to also establish your place in the world. So when we limit it simply to the verbal modality, it is such a loss to the human story.
Thank you. There are quite a few comments, and I want to just read one or two of them interspersed with questions, because I think they're important as well in terms of people's response and reflection on your presentation. One is, Dr. Mathew, thank you so much for a powerful, evocative presentation. It was so meaningful and encouraging to be, like you, agents of change in promoting justice and bridge building process of emoting compassion and understanding. Thank you, Dr. Mathew, for such a clear, enlightening presentation. I learned so much. Here at HSS, we, of course, are very tuned into mobility issues for our patients. Do you have any recommendations for us in terms of ways of being more sensitive to other forms of disability or those that are not visible? Which is, in part, I think, what you shared in an earlier question, but if you care to elaborate.
I would say, mental health is always such a difficult thing to address, that when people come, the minute they walk into a hospital, what happens is innately it activates the threat response, the flight, fight, or freeze response. And the research shows that when we're in an activated state, we have less access to language, to creativity, to problem solving. So to remember is that, so in traumatology theory, what they say is calm, safety, and hope. Can we first activate a state of calm? How is that done? Through social and relational medicine. I see you. I hear you. Welcome today. Is there anything you need? That may seem so obvious. But remember that the human care comes from a reference of care. And so many people, when they're marginalized, only have the experience of being ignored, of being dehumanized. So one moment of tenderness can illuminate a life. So calm, safety, and hope. Is this a safe place? And we know that sometimes hospital settings, you hear this over again, are re-traumatizing. You're going to a hospital to get help, but the hospital environment in itself is traumatizing. Are we mindful of noise, context, spacing, seating? Really thinking out of the box, bringing in that creative lens. How can this be a safe space? Think of the safe spaces in your world, your bedroom. You go there and you just exhale and you say, oh, I'm safe. Imagine if you go to a hospital setting and you can say, no, this is a safe place. And the third thing in traumatology is hope. The hope that people will rigorously conceptualize a treatment plan for you that includes your voice and with creativity, to think out of the box. So that's the one thing I want to offer to the audience about the lens of creativity. What I know over and over again, we can imagine more than we see. We can imagine more than what's in front of us. But we don't have the opportunity to do that for many complex factors. We know that the reimbursement structures narrows the clinical encounter sometimes to 10 minutes, 15 minutes. It's not humanly possible to sometimes engage in a full relational encounter where people can feel anchored. So this is an issue that needs to be dealt with directly, systemically, from an organizational perspective, but also to be a policy advocate, to write to the local governor, to write to your local congressman, and to be persistent.
All of this so foundational. Thank you. Another comment, reflection on your presentation. Thank you so much. I feel like your talk has ignited a very positive fire in my mind. It's good to hear that. I want to encourage, as I'm also sharing comments, thoughts, reflections, reactions to your presentation, to encourage others to also share some of their thoughts and reactions. It doesn't have to be a question. It can just be, how this lands, what how you're processing this, what you're thinking, what you're feeling. Any other comments, questions? I'm waiting. Somebody's typing, so. We've seen through the pandemic how tangible it is to create accessibility when the need for it is deemed worthy by those who have the power to make decisions. I've seen the frustration in the disabled community as they watch the world shift to accommodate circumstances which so many disabled persons have been living for so long. Can you speak to how the pandemic has illuminated the disabled experience?
You know, I want to go back to the idea of universal access is for all. So telehealth visits, thank goodness now it's an option. It's not only helpful to people with disabilities, it's helpful to the single mother who has children and can't afford a 45-minute drive to the hospital and back. It's helpful to the person who has an aging parent at home and has to go pick up kids at the end of the day. So what I want to say is this model of accessibility is more in line with the journey of human vulnerability and need over the lifespan. That this dichotomy of the disability and ability framework is a flawed framework. That, yes, the pandemic shifted things overnight and reconfigured when it was convenient for people who had power and privilege. But what I've observed is that it's opened the door. For example, there's what's called food deserts, treatment deserts, access deserts throughout the country, where the closest hospital is maybe an hour and a half away. So a telehealth visit would give someone access to a solid clinical evaluation that they wouldn't have the privilege of having. So again, I want to broaden this lens to say the way that people with disabilities have moved through the world offers tremendous insight. I know from my world and the world of the post-polio community, the tremendous innovations that have come out of this world with hand controls, adaptive devices, that it's not just a diagnosis, it's a lived experience. It's an insight into the world. And as I said in my last slide, as a public health activist, as I'm very concerned about the emerging need that's coming out of disaster-related stress, the long-haul COVID community, the aging population in the US, there are going to be countless communities that need models and structures of resiliency care.
Thank you. I see more people typing. I'm going to share a few more reflections and also just want to really encourage. We have several minutes left with Dr. Mathew, and I just want to encourage you to use this time really well. Thank you for this insightful presentation, validating many of my thoughts and feelings. Another person comments, thank you for this illuminating lecture. Looking for additional questions. I see that there are some people with raised hands, and I want to encourage you to type your questions in the chat. In the meanwhile, I'm going to share another question that I have from registration. When meeting a new patient, how do I know whether to use person first or identity first language? What language can I use when I approach patients?
First, what I'll say is you don't know. You won't know until you remember. What I would say is first, what I always find, because I'm also a practitioner, is I always connect to the basic experience that we're shared. We're both humans. We're both people. And then through the intake process or through the connection process, asking the questions with, I think, sincerity, with curiosity, with respect, that's also really important. The way things are asked, the tone, and also the presence, the nonverbal presence. We humans have the ability to sense each other before they can make sense of it conceptually. So it's really important that we simply ask, and we stay open, and we stay curious, and we don't know until we ask, and know that it's evolving. Who we are today is not who we are tomorrow. As we metabolize all the complexity in the world, next year, it may be different the way that this year. But what's more important to me is definitely ask, but ask with the right presence.
You know, I think part of that question is I'm not sure how to approach this, and I'm worried about making a mistake. And so what if you make a mistake? what if you approach it in a way that is not, the patient does not feel heard or seen? How do you recover that? Because I think that that's an important skill in clinical skill.
I would definitely say to acknowledge it, and also to convey the sincerity that you have, that you're here to want to learn, and you're here to want to build that bridge. We are all going to make mistakes. We're all on a learning curve. And also, if they do have a frustrated reaction, to let them have that moment. Because, you know, that may be the 10th time in this week that that happened, right? So just letting that person have a moment to be able to have whatever feeling they're having, because you don't know what their week or their month, like you don't know how many times that macro or microaggression has occurred in the course of a week. So letting them have that experience, acknowledging it, but also conveying. What I always say to an audience when I'm working with students is that I'm not perfect. I'm a person in process. But what I say is you will always have my commitment and you will always have my effort.
Yes, thank you. Another comment. It's truly a fabulous presentation, and I wish they could be shown to the whole hospital and for all of our patients. And I would agree. I'm looking for other questions. I know there were one or two people who had raised their hands, and I really do want to encourage you to type in, even if it's in shorthand, in the chat box, and we'll interpret for you. We have a great justice committee in the community, and I, from your lead, will share your compassionate learnings and issues. Can you put me on your mailing list? And I'll share that information with you. Any other thoughts, reflections, ideas, comments? I'll wait for another moment, because I know that we have people in the background who are helping to type in some of these questions. While we're waiting, although I feel like you've punctuated this at different parts of the presentation and in the Q&A, any takeaway thoughts about how we can help and be allies in the healthcare setting and in life?
Yeah, well, I would love to see more people get involved in policy work, get involved in speaking to their local congressman. What I said the one thing I'm concerned about at this stage of my career is the model of resiliency care. You know, the in-between between preventing disease and treating disease. That so often, so much is not accessible in that, and people being able to maintain the highest quality of life they can as they are, and how critical that is. And the reimbursement structure is not set up for resiliency care, where people feel, almost criticized or blamed, for then showing up at the hospital again. So definitely policy work, justice work. But I also have seen over the years, small clinics work in innovative ways with the resources that they do have, in terms of communicating to people coming and seeking care, offering resources, not reinventing the wheel. There's so much out there. We're living at this incredible time where there's access to information and resources, and making sure we make the best use of tools to educate people and to let people to know what's available and accessible to them. Also in multimodal ways. The one thing I love with the Parkinson's, the Dance for PD Parkinson's community I work with, they are a model of accessibility. They have in class, they have Zoom, they also have by phone for people who are not comfortable with it. So they make it accessible in so many ways. So to make sure that we don't recreate the wheel, and then we access and put together the resources that are available, and make the resources available in a variety of ways. For the visually impaired, for the low vision community, for the deaf community, for the people who are not technically savvy, that we've really thought of multiple portals of entry for people to be able to access care.
Thank you. And I want to thank you again for curating that beautiful resource list that we can all draw upon. I want to thank you again for your presentation, for your generous time and expertise in answering all these questions as well.